Welcome for this media briefing. My name is Dr. Anthony Kamau. I'm the Acting Director Clinical Services in the hospital. So today we are celebrating a big milestone. And this is a milestone we celebrate or we engage in every year, where we invite international faculty and local faculty to do what we call breast reconstruction and aesthetics. So it basically means I'll just give a case scenario so that we capture what I'm talking about. If a woman goes through a mastectomy or the breast is removed, how do you reconstruct that breast so that that space does not remain flat, if you like, or without, so it helps to just reconstruct, make her look like the woman that she was again. Of course, that gives her the self-esteem that she had previously. So in a nutshell, that's what this workshop is about. I hope I've explained it in a way that does justice to the technical team. We know that breast cancer for us is a big issue, and I say the statistics are not good. A lot of women come with late breast cancer, and because of that, most of them end up having to do mastectomies. That's removal of the breast. And of course, now the sequel or the after that is then the reconstruction and the aesthetics that are done by the plastics and an aesthetics team. In KUTRH, we have what we call a comprehensive breast care center. And that comprehensive breast care center is something that we started as a result of seeing the statistics. So basically, it's a place where women come for screening. So in the regular cancer clinic or cancer center, you may have a waiting time of 3 weeks or so. But in this clinic, women just come and are seen on the first day. And within 3 weeks, they most likely will have their surgery done after all the necessary investigations have been done. In the hospital, we are also looking at a multidisciplinary approach. And as we said, oncologists are involved. So we usually have an MDT, what we call a multidisciplinary team meeting every Monday to discuss these cases. So the plastic surgeons are represented, the oncologists are represented, those who do radiotherapy are represented, and so on. Something I would like to highlight is the role SHA has played, especially this year. We've seen that SHA has really committed to these procedures. Before, we were not having assurance that they would be covered. So it would be a hit and miss, or you are not sure whether when you put the pre-authorization that procedure will actually be approved for the surgeons to actually do the procedure. Starting this year, we'd like to thank the government because that has become consistent. Whenever we apply for those reconstruction, there's a procedure amount given for reconstruction. There's a procedure amount given for, you call it what? Reduction. So all these things are covered right now under SHA. So finally, I would like to appreciate the local and the international faculty who came and are here with us. And you'll allow me to ask one of the international faculty to say something on behalf of the team. Nancy? Yeah, please welcome. Yes.
Before she proceeds,
yes.
Can you give us some statistics, I think, on the statistics of the cases you have done in this hospital, and also the cost implication? How much would it cost, for example, per procedure versus replacement?
Okay. So I don't know that you wanted us to pick the questions first, or we finish then you pick the question. Okay. Then I'll ask Dr. to say something. Okay.
Yeah. So specifically for this workshop, we've operated on 13 patients. On average, when we started the unit in 2021, we were probably doing about 1 case every year. In 2022, we about doubled or tripled the cases. This past year, we've done about between 6 to 10 cases in the year. So year on year, we're increasing the number of cases we're doing. And that is just evidence of how helpful workshops like this actually are to us. So this week, we've done 13 cases, and that counts towards what we've done this year. We hope by the end of the year, we'll have probably hit around 50 cases. The average cost, if you're looking at both reductions and reconstructions, is anywhere between, at this hospital, anywhere between 100 to 200,000 shillings if you want it done well. The cost will also vary depending on whether an implant is required, for example, because that becomes an additional cost to the patient. But on average, between 100 and 200,000.
What percentage does SHA cover of that cost?
For the breast reconstructions, the SHA approval is 112,000 shillings, and for the breast reduction, it's 168,000 shillings. Okay.
And this is the second time I have attended this workshop, and I was very delighted when I was first invited, and I was particularly delighted to be invited back a second time. I'm hopeful that our team, which is from many different countries, is able to do some information and skill sharing with the local team. And at the same time, we learn from the local team what their techniques are and also what their obstacles might be to moving forward. And hopefully we can collaborate on that again in the future. The dedication of the staff at this institution has been very impressive. Every single person, from the scrub nurses in the operating room to the nurses on the ward, anesthesiology, the surgeons that work here, they are all very, very committed to making this a success. And anything that our team can do to help promote that success in the future is something that we would like to do. I've certainly enjoyed meeting the local surgeons as well as the surgeons from other countries, and I'm learning from them all the time. This is an extremely important initiative. You have just completed the first step that we had to complete years ago, which was getting women diagnosed with breast cancer earlier. I think that's the #1 priority, is the screening center that's been set up. Then what happens after you have the screening center is you now have patients with cancer. You have to do something about it. So now you're able to diagnose it, so there's no point in having a diagnosis if you can't follow through and provide appropriate treatment for it. And now you're heading into phase 2. And then phase 3 will be just optimizing the treatment and the care subsequent to that. So there's been a very good start. I'm happy to answer any questions that you might have for me, but I think the team might be able to participate a bit in any of the questions that might be answered at this time.
Say in comparison to Canada, how are we doing as a country?
Based on early diagnosis. So what you have achieved here now is early diagnosis. And I know that you have the appropriate neoadjuvant therapies to support the cure of the cancer, and now you're developing the surgical expertise. It's difficult for me to compare what your survival rate here is to ours in Canada because I don't know what your diagnostic rate is. If we knew that every patient who had breast cancer here or any type of cancer was diagnosed early and had appropriate treatment, we would be able to make a more fair comparison. At this time, I'm not sure that it's fair to make that diagnosis. What we do know, I think in every country in the world, the incidence of breast cancer is going up and up and up, and the age of diagnosis is going down and down and down. This year, I've operated on many women in their late 20s and early 30s who have been diagnosed with very aggressive breast cancer. So it's certainly an initiative that needs to be respected and it needs to be followed through on. It's always difficult to lobby for support for one specific disease entity because there's so many other needs in healthcare. There's trauma need, there is the need for other types of cancer, there's the care has to be required for prenatal and postnatal. So it's about lobbying for the need you have, but also appreciating that we have a limited resource base everywhere in the world. So you have to make sure that the resources you spend on the patients that you diagnose are also appropriate. So we can have a dream of how we treat things, but we also have to be a little bit practical, and I think that's a universal challenge that we have.
In our country, we perform a lot of these kind of surgeries in the field of breast reconstruction, but we didn't have, I did not have the perspective what mean breast cancer here in Africa, because I have been previously in other countries like Tanzania for cleft lip surgeries, but I was surprised because of the high level of the surgery here for breast cancer. I think, as Dr. Van Leken said before, that probably the limits here are not the professionals. The limit here to have early diagnosis of cancer, to have good rates of survival. This is crucial. That's the point, because I saw that the professionals, not only the doctors, that very good doctors and with very good formation, also the nurses and all the staff, they work hard to provide what the patient needs to restore her life after this devastating disease. So I think that you have a good field to grow more, because the field have a good soil for that. Thank you. I'm Dr. Joan Fondevila from Barcelona, Spain. I'm chief of the Plastic Surgery Society of Spain and chief of the Department of Plastic Surgery Hospital Clinic in Barcelona.
And then Dr. J.P. Ogalo will add. So when I looked at the cross-section of surgeries that had been done, breast reconstruction surgeries in Kenya that had been done this year, I could only cite 3 places and 3 initiatives that had been done. I think 1 at the coast and 2 in Nairobi, 1 in KNH and 1 here today. So it's something that is gaining traction, but we'd like to see more. And I think these kind of initiatives help us to leverage on the expertise of other faculties so that we can increase the leverage and do more of these surgeries in Kenya. Right now, I'm sure if we did a poll of the number of women who actually need this service right now, those who may or may not know, because sometimes not knowing is a hindrance to accessing the service. Yeah. JP, you have something to add?
Yeah, sure. The beauty about this forum is that we have experts from across the country and also across the continent to help answer that question, and I'll invite them on just after I've given my remarks. But we've done our own local data in terms of breast reconstruction, and what we found out was about anywhere between 5 to 10% of the patients who have their breasts removed because of breast cancer end up getting a reconstruction. So our challenge now is to increase those numbers so that we get majority of our patients undergoing the breast reconstruction, or at the very least being offered the option of having a breast reconstruction done. That's usually the bare minimum. They need to know that this service is available. In the country right now, you can pretty much get a breast reconstruction done in any hospital that does have a plastic reconstructive and aesthetic surgeon. And as Dr. Nancy said, the personnel is not so much the issue. Our challenges tend to be on the side of equipment and having the hospital staff plastic surgeons within them. I'd like to ask Dr. Kahoro to give a comment on Kenyatta National Hospital, and then Dr. Kwame on the situation in Ghana.
Thank you very much. My name is Dr. Lois Kahoro. I have worked for a number of years at the Kenyatta National Hospital. Yeah, and we do offer breast reconstruction as part of what we offer our patients. I think the biggest challenge is availability of that knowledge to the patients. So some patients are not aware that reconstruction. Some are not so sure whether they want to have it. And also the availability now of the resources of being able to pay upfront or to pay through NHIF. For Kenyatta, the patients do use NHIF and SHA now, but if they want to do it privately, then they would have to most likely pay from their pocket or through the insurance. And as you know, that our uptake of insurance in Kenya is not very, very high. So those are the challenges. And I think maybe we do compare favorably with other African nations. Maybe, of course, the rest of the world may be ahead of us in that aspect. Thank you.
So thank you very much. My name is Dr. Kwame Dako. I'm a consultant plastic surgeon from Accra in Ghana, specifically with the Kolebu Teaching Hospital. So what I would like to say is that I think the journey is never easy, but I think where Kenya is at the moment, or this hospital is at the moment, I think back in Ghana, in my hospital, we were at this point about 9-10 years ago. And the traction will come very quickly, and it seems there's a lot of acceptance. The key, as has been said by the other speakers, is early diagnosis, and then they are initiated into a pathway of treatment, which would include breast reconstruction. A few papers that came out from our side of Africa indicated that for late-stage disease, which we don't want, the survivability across continents is about the same. And in fact, for early-stage disease, that's when the cancer is caught very early, the survivability comparison is actually with more westernized cultures. But the problem is actually picking up the patients or the clients at an early stage. So that's the hurdle that needs to be jumped over, and once you can, and those who see the patients up front, who help make the diagnosis from the beginning, be it your screening nurses, screening doctors, the general doctors, general surgeons, or whoever it is, are also made aware of the possibility of breast reconstruction and the wide spectrum that is also available if you have the right training, the right armamentarium for the procedures. And we hope further workshops like this, which have been really supported by this hospital, would also help to spread the word and also to equip with increasing skill, because we're all learning at the end of the day. Thank you very much.
Any more questions?